So I would like to thank the organizing committee for organize this symposium, this session, educational session on cytomegalovirus infection in organ transplantation, new strategies for an old problem. Thank you for attending in person and online the session. I will be one of the chair, one of the speakers. I'm Maddalena Giannella, an infection disease specialist from Bologna. With me, there are Professor.
I'm Dori Segev, a transplant surgeon from Johns Hopkins. I will be the other session chair. I'm not an infectious disease doctor, but apparently I count as one. So I'm an honorary infectious disease doctor for the next hour and a half.
I will be 5 presentations. 3 of my colleagues of the speakers have pre-recorded the session, and then there is Professor Paolo Solidoro from Torino who is here and will give the presentation in person. So I will start with the first presentation on CMV management practice across Europe, results of an ESOT survey. From the speaker is Nassim Kamar from Toulouse, France. Please.
So, ladies and gentlemen, I would like to thank the organizer of the ESOT for giving me the opportunity to present the results of the CMV management practice across Europe, the results of an ESOT survey. I'm presenting the data on behalf of all my colleagues of the working group. They are listed on this slide. Here are my disclosures. So the aims of the ESOT survey were to describe the management of CMV worldwide and to evaluate whether the international guidelines that have been published 3 times were used by transplant centers. So it was a questionnaire-based cross-sectional study conducted between July 19 and October 19. Its content was 57 questions, and it was required 30 to 40 minutes to fill the survey online. The survey targeted all ESOT contacts, around 8,000 persons, and we obtained only 237 full survey responses. 13 was discounted, and finally we analyzed the result of 224 responses. There were 144 transplant physicians, 40 transplant surgeons, 29 transplant infectious disease specialists, and 11 from other specialties like immunologists, intensivists, etc. Most responders were European, 85% were from Europe, especially from Spain, the UK, France, Italy, and Germany. We had also 7% of responders were from South America, 6% from Asia, 2% from North America, and 1 responder from Australia. Here are the demographics of the responders. Most of them, nearly 80%, were taking care of adult transplantation. 5% were performing pediatric transplantation, and 16% were doing both. The mean clinical practice time was 14.1 years, and most of them, nearly 64%, were in charge of kidney and kidney pancreas transplantation, 21% of liver transplantation, and 15% of thoracic transplantation. And if we look on the left, on the right part of the slide, you can see that the median annual number of transplantation performed by the centers of responders were nearly 100 for the kidney, 51 for the liver, 25 for the lungs and heart, and 10 for the pancreas transplantation. The first question, one of the first questions regarding the management of CMV was to discuss the diagnosis tools that were used by the centers. And the large majority, nearly all centers, were using CMV anemia, and especially they are using the quantification of CMV anemia. However, we observed that nearly 2/3 of the centers were using whole blood CMV anemia, while the others were using plasma CMV anemia. and very few centers were using PP65 antigen. One of the main findings was the huge variability in the threshold for initiating preemptive therapy. We will go back later on for the prevention methods, but for those who were using a preemptive therapy, there were a huge difference in the threshold that was decided by the centers to initiate this therapy. And you can see it on the upper part for the liver transplant patients, on the bottom the heart transplant patient, and here are the kidney. If we look for the median number of copies, it was the same for whole blood and for plasma, 1,000, but it ranges from 10 to 10,000 copies per mil for the plasma, and from 5 to 20,000 copies per mil for the whole blood. So there were really large differences between all centers. What about the prevention of CMV infection and disease? We split the results in D plus R minus patients and seropositive patients. For D plus R minus patients, 90% of centers reported using prophylaxis. And most of them, 95%, were using and 5% were using. In addition, in 8% of cases of centers, they were using immunoglobulin specific against CMV. And finally, 12% reported performing a hybrid strategy, which means giving prophylaxis followed by a surveillance of the viremia. The main point is that the monitoring that was performed after prophylaxis was completely different from one center to another, ranging from one assessing the CMV anemia once every week to once every 3 to 6 months. With respect to the duration of prophylaxis, for heart, kidney, and kidney pancreas, the majority of the center were giving 6 months prophylaxis. Those are the light gray columns. Conversely, for lung transplant patients, the majority was giving a prophylaxis for 1 year. Some few centers were also giving 3 months prophylaxis, especially in liver transplant patients, where patients were given either 3 months or 6 months. What about seropositive patients? For seropositive patients, nearly half of the centers were using prophylaxis, and the second half were using preemptive therapy, especially for liver transplant patients. 18% of centers reported doing no prevention for D plus, R plus, and 26% no prevention for D minus, R plus. So there are some few centers not giving at all any, having no strategy to prevent CMV in seropositive patients. With respect to the duration of prophylaxis in the centers who opted for the prophylaxis in this setting, the majority of centers were giving 3 months prophylaxis, this is the white columns, except for the lung transplant patient again, who patients were giving either 6 months or 12 months prophylaxis. One of the issue was pointed out by the responders was the neurotoxicity of the drug that is used for prophylaxis or for therapy, and neurotoxicity was reported in 64% of centers, and it prompted the discontinuation of prophylaxis in at least 10% of patients. What about the treatment of CMV disease? The main drug that was used to treat CMV disease was IV ganciclovir in 76% of cases. But surprisingly, we have also 62.5% of responders reporting using valganciclovir. So probably the explanation is that some centers are starting the therapy with IV ganciclovir and switching afterwards to valganciclovir. CMV IVIG were used in 14% of centers, in addition to IV ganciclovir or to oral valganciclovir, and they were used mainly in primary CMV infection in D plus R minus patients, mostly in lung transplant patients, In patients having hypogammaglobulinemia, less than 500 milligram per deciliter. And for the patients having a severe infection, severe leukopenia, GI CMV infection, or pneumonia. With respect to the resistance, the use of molecular diagnosis approach for detection of CMV resistance were reported in 45% of centers. However, 1/3 of the centers reported the testing of resistance is not available in their center, and 15% were not aware whether testing was available in their institution. The rate of ganciclovir resistance was reported to be in less 1% of patients and 75% of responders, between 1 to 5% in 23% of centers, and between 6 to 10% in only 5 centers. So the most resistance, it's less than 1% in amongst responder centers. Regarding the treatment of resistant CMV, transplant centers are mostly using a high dose of IV ganciclovir, but they were also using foscarnet. Especially, it was most likely following the high doses of ganciclovir. Cidofovir was given in 21.8%, and IV CMV immunoglobulins were given in 1/3 of patients in combination with antiviral therapy. And finally, 1/3 of patients reported converting patients with ganciclovir-resistant CMV to mTOR inhibitors to try to clear the virus. Regarding the monitoring of CMV-specific T-cell response, it's not performed in the large majority of centers in routine settings, more than 80%. Those who were offering this facility were using especially quantiferon followed by ELISpot. And the perception among responders regarding the importance of CMV-specific T-cell response, it was not very important in the majority of the patients at the time of the survey, but in 1 or 3 years, there was a change, and the people who responded to the survey think that it will be somewhat important or very important in the future. So we have to still have to move forward to implement this monitoring in the centers and to try to use it routinely. Among the questions, there was a question asking what are the key issues in CMV management in solid organ transplant patients. And the 5 most highly related topics were the drug toxicities, the late CMV infection, the ease to administration of this drug, the management of CMV resistance, and the drug cost. With respect to the perception of the future research and development on in the CMV fields and ESOTs, the 5 responses with the highest weighted average score were the optimizing of immunosuppressive protocols, the long-term impact of CMV on graft dysfunction and comorbidities, personalized anti-CMV strategy based on the monitoring of CMV-specific T-cell response, vaccination against CMV, and the use of the discovery of new drugs. At that time, letermovir and maribavir were used in randomized trial and were not still not approved for to be used in all centers. So in summary, the survey showed that a heterogeneous approach to the management of CMV, especially for diagnosis, for the CMV treatment and the treatment of resistant CMV, and a divergence from the international management guidelines that have been published 3 times. So there are still unmet needs that should be addressed in the future. And I would like to thank you for your attention. I'd be happy to answer to your questions.
Thank you, Dr. Kamar, for this very interesting overview of the survey. I will present the next speaker, RAtul Humar from Toronto. The title of the talk is Patient at High Risk for CMV Syndrome Disease, not only donor positive or recipient negative.
Thank you very much for inviting me to present at ESOT. I'll be discussing patients at high risk for CMV syndrome and disease, not only D+, R-. These are my disclosures, and these are my objectives. So I will discuss risk factors for CMV disease and discuss how new strategies can help define risk. Just some background, CMV remains the most common viral infection in solid organ transplant patients. Here I've provided a schematic of the virus. So there are two unique regions of DNA, unique long and unique short. There are a large number of functional genes encoded by the virus, and CMV expression, gene expression occurs in a temporal cascade. One of the key regions is the major immediate early promoter region, and it's one of the first promoters to activate upon infection, and I'll talk a little bit more about that in subsequent slides. Now, the main risk factor for CMV remains the donor and recipient pre-transplant serostatus. So the D+, R- subgroup remains at high risk. The D+, R+ and D- R+ are at intermediate risk, and the low risk is D- R-, provided that either seronegative blood products are used or leukodepleted blood products are used. Now, the rest of my talk, I'll be focusing on beyond D+, R-, what are the risk factors? And this slide basically summarizes that the risk is based on a combination of viral factors and host factors. The viral factors are actually quite poorly understood, but include replication dynamics, immune evasion, so the virus produces a number of proteins that are responsible for immunoevasion, viral heterogeneity, and viral co-infections with other herpes viruses particularly. Host factors include the CD4 and CD8 T cell count, the other aspects of the immune system as well. And much of this is mediated by the exogenous immunosuppression, as well as the donor-recipient serostatus. Now, what happens after transplant is latent virus, either of donor or recipient origin, is reactivated, and the virus is actually intranuclear and reactivated. And the inflammatory response seems to play a key role in this, including cytokine production, NF-kappa B. And actually what happens is that the inflammatory response results in activation of the major immediate early protein with subsequent production of immediate early viral proteins. And this can be driven by immunosuppression, especially anti-lymphocyte antibodies, other herpes viruses, rejection, and even the surgical procedure itself. Then what happens is that the immunosuppression plays a permissive role in viral replication. So normally you would have a brisk immune response, especially a CD4 and CD8 T cell response to limit viral replication, which does not occur in the transplant recipient. You get uncontrolled viral replication and CMV disease. Now, prevention affects the presentation, and this is very important. So what we've seen is that the use of widespread prophylaxis especially has resulted in the decrease in severe disease. And what we're most commonly seeing is mild or asymptomatic viremia. Now, how do we clinically assess risk of CMV reactivation beyond D+ R-? Well, there's also the immunosuppression, doses and levels, the type of organ transplanted and the function, the lymphocyte count, hypogammaglobulinemia, and other factors in addition to the pre-transplant D and DR CMV serostatus. Now I'm going to talk about some of these. So the first important point is that the organ matters. So this is a recent study by Hernandez et al. Published in American Journal of Transplant that looked at 428 D+ R- recipients. And they looked at the rate of CMV reactivation after transplant. And it was highest in lung, followed by liver, followed by heart, followed by kidney and kidney pancreas. And this was independent of the duration of antiviral prophylaxis and the immunosuppression. So the organ transplant is clearly a risk factor for CMV transmission and reactivation. And this might in part relate to the viral burden within the allograft. The other major point is that immunosuppression matters. And what we know from many transplant studies is that immunosuppression has different effects on different pathogens. So for example, thymoglobulin is known to have a diverse risk of opportunistic infections and an increased risk of herpes virus reactivation, including CMV and EBV, and it's a non-specific targeting. mTOR inhibitors, on the other hand, have been shown to result in a lower incidence of CMV and possibly of BK virus, and this may be because mTOR is an important component in the viral replication cycle. Eculizumab inhibits terminal complement and increases risk of meningococcal disease. Mycophenolate, on the other hand, may decrease your risk for PTLD versus other comparable agents due to inhibition of B-cell proliferation. Belatacept increases your risk of CNS PTLD likely, although the mechanism for that is unclear. Now, what about for CMV? Well, thymoglobulin has always traditionally been a very important risk factor for CMV. However, what we're learning now is that the dose and the timing of thymoglobulin matters. So clearly, if you give thymoglobulin for treatment of acute rejection, it increases your risk of CMV. However, in this study of 630 kidney transplant recipients, they compared conventional dosing, which was typically in the range of 4 to 5 milligrams per kilogram, versus reduced dosing of thymoglobulin. And they showed that with the reduced dosing, you had a much less significant effect on CMV reactivation without any significant effect on graft function or acute rejection. Interestingly enough, other immunosuppressions such as belatacept has also been studied, and in this recent study in American Journal of Transplant, they looked at 308 seronegative kidney transplant recipients, of which 168 received seropositive organs. 203 were belatacept treated, and what they noted is in the high-risk group, belatacept was associated with a higher rate of CMV viremia and a longer time to viral clearance. Now I'm going to discuss the immune control of CMV and how we can use that to help define who's at risk of CMV. So the immune control is very complex. It includes a combination of innate and adaptive immunity. And I'm going to focus on the adaptive immunity, especially the CD4 and CD8 T cell response to CMV. Now, how can we use cell-mediated immunity to stratify patients' risk? So basically, this is a summary diagram of that. High CMI, high cell-mediated immunity, equals low risk of CMV disease. And the way this is typically measured is that antigens and peptides are used to stimulate the patient's cells, and then the output, which is T cell production of a cytokine, often interferon gamma, is measured through a number of different methods, including assays such as quantiferon CMV, ELISpot assays, or flow cytometry-based assays. And I'll talk a little bit more about these. Now, many of these are commercially available, although the availability does vary upon country to country. This is the quantiferon CMV assay. This is an ELISA-based detection of interferon gamma, where the tubes are coated with a mixture of peptides that are specific to CD8 stimulation across a variety of HLA types. And this assay is relatively easy to perform. The patient's blood is collected in the tube, it's mixed, incubated overnight, and then there's an ELISA for interferon gamma done. Another commonly used assay is an ELISpot assay, which quantifies interferon gamma secreting cells, usually as spot-forming units after stimulation with peptides, typically IE1 or PP65. And it measures total interferon production by CD8 or CD4 T cells. The threshold for a positive here depends on the assay you used. I've just shown diagrammatically a positive assay here versus a negative assay here. And on the right here is a positive control for each patient. And then the final assay that's commonly being used is a flow cytometry assay. And this really provides the highest resolution of data for cytokines, either interferon gamma, but you can also measure other cytokines. And you can also look at both CD4 and CD8 T cells. It's commonly used as a research tool in many labs, but it is also now commercially available in some jurisdictions. There are some challenges in standardization, but that is slowly improving over time. Now, how do we use these assays to predict CMV? Well, this is one commonly used method. So this was a study by Oriol Manuel et al., where everybody got prophylaxis. It was 127 D plus or minus patients. And then they had CMI testing at the end of prophylaxis in order to predict CMV disease. And what they found here was using a cutoff of 0.2 IU per ml, those with a positive CMI assay at the end of prophylaxis had a very low rate of subsequent CMV, while those with a negative CMI had a much higher rate of subsequent CMV. Similar data exists using an ELISpot assay. This was a study in AJT looking at 368 patients with regular ELISpot monitoring using the T-spot CMV assay. And they found that especially in the R-positive patients, the ELISpot result was very predictive of CMV reactivation. So here are some potential clinical scenarios for CMI use. So the first is CMV D plus on primary prophylaxis, CMV R plus with other risk factors, recent completion of therapy for CMV, and recent completion of therapy for symptomatic CMV. And really what the assays could be used for here is for a negative assay, you give ongoing prophylaxis or frequent monitoring. For a positive assay, no further prophylaxis or monitoring. And then another clinical scenario is low-level viremia, where you may predict whether you need to treat the patient or not. Now, why are these not more widespread used in clinical testing? One of the problems is it's difficult to conclusively demonstrate clinical utility of these assays. So what we need is more interventional studies. The endpoints are changing. Previously is CMV disease, and now we don't see as much CMV disease, so it's CMV viremia or treated viremia. Studies with one diagnostic assay don't necessarily apply to another, and there's regulatory approval either lacking or it's different from country to country. And this makes for a very difficult commercialization pathway. So in summary, although CMV D plus R minus status remains a key risk factor for infection, the pathogenesis of viral reactivation is complex and driven by numerous factors that involve both host factors, viral factors, immunosuppression, and others. And I hope I've shown you today that an improved understanding of the mechanisms behind CMV reactivation and the immune response will further help us better predict CMV post-transplant. I'd like to also highlight the recently published guidelines in the last few years. So the first is the International CMV Consensus Guideline by Camille Cotton and others. This was published in Transplantation. And the second is the American Society of Transplant Guidelines by Raymond Rezenabla and myself, published in Clin Transplant in 2019. So thank you very much for your time. And once again, thank you for inviting me to present today.
Our next speaker is here. It's Maddalena Giannella, our co-moderator as well, to speak about unmet needs for prevention of CMV infection in transplantation, challenges in management of drug toxicities, and viral resistances.
These are my disclosures of conflict of interest. I have prepared this talk around a case we recently managed at our center. This is a 36-year-old man with prior history of alcohol and drug abuse. His cardiological history started in 2018 with an ischemic cardiac disease followed by chronic heart failure requiring ICD implantation, valve repair, and at the end also VAD implantation has bridge to transplant. Heart transplantation was performed on April 2020. The patient had high risk for CMV primary infection as donor was positive, serostatus of donor was positive, and that of the patient was negative. So we started as soon as after transplantation prophylaxis with valganciclovir. 4 months later, the patient complained gastrointestinal and also cardiological symptoms. So we perform determination of CMV DNA on blood, finding replication, and also there were findings at myocardial biopsy of tissue invasion. So we start with we shift from oral valganciclovir to intravenous ganciclovir as standard dose, but at the same time we suspected for drug resistance, so we request a test, and also we perform quantiferon CMV to assess the presence of specific immunity. Of course, we started with first-line treatment. All of us, we are very familiar with these drugs. We know that main, as also said in the prior survey results, the main problem with the ganciclovir and valganciclovir are myelosuppression and kidney toxicity. Mainly these two adverse events are followed by reduction of doses or also withdrawal of drugs. All these factors can favor antiviral resistance that is increasing in the last years. The main risk factors have been described in several reports, and we have severely impaired CMV-specific immunity. This is one of the reasons we request for quantiferon, high viral loads, and also the last one is the most important, in my opinion, in clinical practice, the prolonged viral replication in presence of incompletely suppressive antiviral drug exposure. And I would underline that in most of our centers, the therapeutic drug monitoring of valganciclovir and valganciclovir is infrequently done or also not available. The largest series, I think that all of us know very well this series published on clinical infection disease in 2017, where the authors compare 37 cases of ganciclovir-resistant cases with 100 control, matched by serostatus, type of organ, and type of CMV presentation to assess risk factors and also the impact on outcome. The incidence of resistance was overall 1%. It rises to up to 4% in high-risk group according with mismatched serostatus, and it reached 12% in lung recipients at high risk. Indeed, in lung recipients, also the time of exposure was lower than in other cases. The other risk factor, as I said before, was the high level of viremia reached during the observation. Regarding the impact on outcome, this was very impressive because all morbidities endpoints like renal function, rejection were statistically significant higher in cases, as well as 3-month and 1-year mortality, also as shown in Kaplan-Meier curve. When to test for antiviral resistance? There is a very well-established algorithm reported on the guidelines recently cited. Authors suggest to test for drug resistance upon prior cumulative valganciclovir exposure that exceeds 6 weeks and treatment failure despite at least 2 weeks of antiviral treatment or development of DNAemia, CMV DNAemia during prophylaxis. What about the new drugs? Here we have not established algorithm. Experts recommend that resistance to new drugs should be considered in case of breakthrough infection during prophylaxis, in this case with letermovir, or failure to have a clinical or virological response to maribavir. And what about the management? I report here the algorithm showed on transplantation, the guidelines. From this algorithm that is a little complex, we can see that the first line remain ganciclovir. We can consider also the use of high dose of ganciclovir in low level of resistance, but when we have high level of resistance, we have to shift to second or third line treatment. Of course, we have to reduce immunosuppression, and we can use also adjunctive therapy, as we can see later. We obtained the result of the genotypic result we requested, showing a mutation on 97 codon associated with resistance to valganciclovir and ganciclovir. The quantiferon test was negative, so we expected that our viremia will go on to improve. So we started with the Foscarnet. We administered also CMV immunoglobulin, and we tried to modify the immunosuppressive regimen, shifting to mTOR regimen, but this was not well tolerated from the patient, so we back to the standard regimen. After 3 weeks of Foscarnet treatment, we obtained a clinical improvement of our patient, and also at biopsy there were no findings. There was an improvement in the findings, and there was no detection of CMV. We follow with therapy, but after 2 weeks we have undetectable viremia. We experienced some problem in managing renal function with fluctuating creatinine level. Indeed, as we can see in this table, the main problem with the use of second and third lines drugs that are Foscarnet and cidofovir is nephrotoxicity. For the Foscarnet, experts recommend to use intravenous fluids to mitigate nephrotoxicity and also to monitoring very closely electrolytes. Some experts use with cidofovir probenecid. However, I have to say that clinical experience is very limited. We have no randomized control trial. We have only observational studies with limited sample size. The largest study with Foscarnet included 22 solid organ transplant recipients treated for refractory resistant CMV with good rates regarding failure or response, virological response. However, as we can see, the rate of renal dysfunction was up to 51%, and it was even higher with the cidofovir, that was 78% in the largest series reported, including 9 solid organ transplant recipients. The other thing I would remember is that cidofovir is associated with higher rates of cross-resistant with ganciclovir, mainly when the resistance is mediated by mutation on 54 codon. So at this time point, 60 weeks of foscarnet therapy, clinical improvement, no further detection of CMV on myocardial biopsy, difficulty managing renal function, and also the need of the patient to have some pause from hospital admission. So we opted for a maintenance arrangement with letermovir, as quantiferon was still negative, I would remember. Letermovir is one of the new drugs. The target is CMV terminase, so there is no problem of cross-resistance. It has been approved for prophylaxis in positive recipients of hematopoietic stem transplantation, but it has been used off-label also for resistant CMV, mainly as maintenance therapy. There are not official doses for treatment, as I remember it has been approved just for prophylaxis in hematological patient. The other drug, as I will see, is maribavir. The target here is 97 kinase, and it has been also used for off-label resistant CMV, as we see later. Some just very few info on letermovir, as there will be another presentation on new drugs. We have to remember when we use CMV for prophylaxis that herpes simplex is not covered. When we use letermovir for treatment of CMV disease, in case of resistant CMV, we have to remember that higher is the viral load at initiation, higher is the risk of failure because there is a low barrier to resistance, according with both in vitro and clinical cases. The other important thing we have to remember when you use letermovir in solid organ transplant recipients is that letermovir is metabolized by cytochrome P450, so there will be drug interaction with the inhibitor of calcineurin. Indeed, with the cyclosporine, we have to reduce the dosage to the alpha 214, and we have to monitor tacrolimus and sirolimus. Regarding the other thing to remember is that letermovir decreases plasma concentration of voriconazole. There have been emergence of letermovir resistance. Here we show these two cases recently published on transplant infectious disease, because here the very interesting thing, in my opinion, is that the author used as induction treatment foscarnet for a refractory CMV infection. Then they opted for letermovir as maintenance regimen. During maintenance regimens, there was an increase in viremia. In the first cases, due to rejection, and in the second case, due to PTLD diagnosis with the withdrawal of cyclosporine. In the first case, the increase in viremia favored the letermovir resistant selection. In the second case, when the authors withdraw cyclosporine, did not back to the standard dosage of letermovir. Probably there was an underexposure that favored letermovir resistant selection. We used letermovir during 4 months with a very well tolerance by the patient. However, 4 months later, the patient presented again with CMV syndrome and increase in CMV level. So we assessed again resistance, finding mutation associated with letermovir resistance. We started, in addition, we have again evidence of tissue invasion at graft level. So we restarted with foscarnet with very difficult management, in this case of renal function. So we asked for compassionate use of maribavir. As said before, maribavir, the target is 97 kinase, so that is important also for phosphorylation of ganciclovir, so co-administration is strongly discouraged because it is antagonistic. Cross-resistance problems have been rarely reported to date. We have to monitor for tacrolimus and sirolimus level because there could be problem of drug-drug interaction. The main is very well tolerated. The main problem adverse events is the dysgeusia that consists in metallic or altered taste, so it's not so very well tolerated drugs. Regarding the use for CMV resistant or refractory CMV infection, it has been used in this phase 2 randomized controlled trial where patients with CMV infection resistant or refractory to ganciclovir, valganciclovir or foscarnet were randomized to receive 400, 800 or 1,200 maribavir twice dose. 2/3 of patients achieved undetectable viremia at 6 weeks. However, 1/3 developed CMV recurrence. And most of them were still on maribavir where recurrence was detected. In 13, mutations associated with maribavir resistance were detected. Back to our cases, after 3 months, the patient presented again a CMV syndrome. We again increase in CMV DNA level. So we tested for maribavir resistance, finding mutation associated with resistance. At this time point, we were desperate. We readmitted the patient at hospital. Restarted again foscarnet because we have evidence of both gastrointestinal localization and graft localization. Here, the we experience a very important renal dysfunction. We manage the patient with our nephrology. We try also to exclude other cause of renal disease. There were not other cause. The immune activity of the patient was very suppressed, so we continue to foscarnet despite the renal problem. But as soon as we achieve CMV negative viremia, we decide to discharge the patient because he was exhausted, and we tried for other 3 weeks to maintain foscarnet at maintenance arrangement at the hospital with the hospital management. But at the end, we decide to stop foscarnet, to withdraw foscarnet, and following the patient by monitoring viremia every week and administering CMV immunoglobulins. So 2 words about adjunctive therapy. As said before, here we have to balance between pathogen and host. And for the host, what we can say, according also with the guideline, what we can do is to switch therapy to mTOR regimen to administer CMV immunoglobulins or to perform an adaptive infusion of CMV specific T cell. The last one is still performed only in very few centers, is still very just for research, but not expanded in clinical practice. Regarding the activity of mTOR, as we know, mTOR can have a direct viral effect, plus they can favor the activity of specific CD8 memory cells. Indeed, in CMV seropositive recipients treated with mTOR inhibitors, a significant reduction of CMV infection disease have been reported. The mechanism of immunoglobulin is complementary with antiviral, as we can obtain neutralization of free viral particles by opsonization and phagocytosis, and also an increase of the activity of T cell cellular immunity. So the use of immunoglobulin, we saw also from the survey, is still not so frequent because clinical data are lacking, supporting prophylactic on therapeutic use when appropriate antivirals are given. So probably in case like our patient facing with the ganciclovir-resistant multi-viral resistant CMV infection, they can be of help. I'm going to my conclusion. Although the availability of new antiviral agents showing high level of short-term efficacy and excellent safety profile, the management of refractory resistant CMV remains an enormous challenge. Probably ad hoc strategies to improve the long-term efficacy of these new agents are needed, and adjunctive therapies aimed at optimize the host response against CMV should be considered for this purpose and investigate in well-designed studies. Thank you for your attention. I would like to thank my co-workers.
Great. Thank you for that excellent presentation. Our next speaker, also here, is Paolo Solidoro, talking about the real high-risk patient when the graft is the site of infection.
Thank you very much for the kind invitation. This is a great opportunity for me to talk about the problem of the graft as a site of infection. I am the second last, and so many things have been said, and this is an advantage because we can go through the clinical practice to understand these topics. I have no potential conflicts, and you can share responsibly these slides. Some years ago, 5 years ago, I was asked with Luciano Potena to understand what was the update for treatment and prevention of a CMV infection in heart and lung transplantation. And the topics, the most important topics, were that heart and lung recipients are highly exposed to CMV infection risk, being lung CMV latency site, viral infection is particularly harmful in lung transplant recipient. Viral reactivation has been associated with direct effects, the organ damage, and indirect effect, acute rejection and chronic allograft dysfunction. Available evidence were unable to support which strategy among preventive or prophylaxis was clearly superior, but a careful planning of CMV prevention strategy was mandatory for appropriate care of heart and lung recipient. Ganciclovir and ganciclovir were pivotal antiviral drugs for therapy and prevention, but we have seen there are problems about toxicity and viral resistance that have to be considered. Agents acting on the immune system, such as CMV immunoglobulins and mTOR inhibitors, represent an effective therapeutic adjuvant approach to antiviral drugs. And finally, thanks to immune monitoring assay, CMV management may further evolve to tailored approaches by matching replication indexes, immunity status, and immune suppressive therapy. So we had to say that strictly, simply, ganciclovir was the cornerstone of CMV therapy. There was an excess of drug toxicity. We have to find a lower toxicity. We have to find the effective CMV risk stratification. Then we have to use immune monitoring assay, and we have to customize the therapeutic approach. So this was what we say in 2016, and in the last 5 years, the situation have been, how can I say, studied a little bit more deeply. We begin with the prevalence of herpes viruses in lung transplantation, in BAL, we find a prevalence of about 70% in patient lung transplanted. And so we have to try to explain this higher prevalence. This higher prevalence could be related either to undiagnosed pneumonia, higher immunosuppression, or to a physiological replication in alveolar site, and the physiological replication doesn't need an antiviral therapy. The problem is to understand when we do not have to use antiviral therapy. It is possible, so, to define when treatment is needed. Let's talk about prophylaxis or preemptive therapy. Prophylaxis is very useful because allow the clinician to reduce immunobiological control, but delayed priming of T-cell immune reconstitution is present, and there's higher incidence of late onset CMV disease. And then there are many costs, how we have seen, and many side effects. But preemptive therapy needs a strict control for CMV reactivation. And so we have demonstrated that when we use immunoglobulins and we use prophylaxis, we reduce acute rejection, we reduce lymphocytic bronchitis, bronchiolitis, we reduce herpes virus infections. In particular, for CMV pneumonia, we have seen we have not a reduction in the first month, but we have a reduction of CMV pneumonia for the first and the second year post-transplantation. So CMV has a pivotal role in this situation, so we have to better manage this situation. How better manage this situation? With a study of immunity. A study of immunity has demonstrated that temporal profile of infection, that duration of infection, that organ disease are strictly related to cellular immune response. And this was something written in 2012. Much more recently, Cotton Humar have demonstrated in a multi-center study the same things about infection, CMV infection, in kidney transplant recipient. And something very interesting is the survival in other kind of transplantation. Just to make an example, in case of allogenic hematopoietic cell, we have seen an increase of death in case of patients with low immunity and with high level of infection. So we find infection plus low immunity as a risk factor for death. And so the CMV ELISpot, the immunological approach, is pivotal in the clinical practice every day. Another step, the use we have seen already in this section of everolimus. This was a study in 2015. Then we have seen something of much more strong about renal transplantation, and the effect of everolimus based on drug regimen for the CMV specific T-cell functionality by Martina Sester and his group has demonstrated that the absolute number of lymphocyte subpopulations were comparable between the arms with everolimus and without everolimus. But the median expression of CTLA4 and PD-1 was higher in the group with EV, lower in the group with everolimus. And the mean percentage of multifunctional CMV-specific T cells were higher in everolimus groups. And so, everolimus-treated patients retain a CMV-specific T cell functionality, which may contribute to enhance the protection against CMV infection. Let's give a look of our approach. Our approach is a tailored approach. In particular, when we have a positivity on BAL, which is the situation in which we have to decide if treat or not to treat the patient, We have to look at the immunity. If the patient is a responder, we can use antiviral therapy. If the patient is not a responder, we don't use antiviral therapy, but we make just a strict follow-up. And when we have frequent specimen positivity for latent responder, we use long-term antiviral therapy, but only in these cases we have the use of long-term antiviral therapy and everolimus immune suppression. The results after follow-up, after 1 year of follow-up, we have performed many studies on the blood and BAL, and this is the group of serostatus, which is a traditional group, plus 63%, plus minus 21%, minus plus 14%, minus 2%. In this group, we had just, differently from the literature, from 4 to 32% of CMV pneumonia, we had just 1% of CMV pneumonia. And this is not different from what we demonstrated more than 10 years ago, treating all the positivities. In this case, we treated just the positivities without a good immunological response. And this is very interesting, I think, where we had both cases of pneumonia, D plus, R plus. So I don't think that the serostatus can be pivotal in our decisions to manage the patient for CMV pneumonia. Probably in the first 30 days of transplantation, this is the only period that we have pneumonia in the first month after transplantation. Probably we had this problem because of the strong immunosuppressive regimen, and as you have seen, regardless of their CMV serostatus. Another topic in this group is viremia. Is the pulmonary infection. Pulmonary infection, we found a 30% of incidence of pulmonary infection with positivity on BAL. And also in this topic, in this positivity, the D plus R plus group was the most represented population. Even if the group D plus R minus had the highest prevalence. So absolutely is a high-risk patient, but don't forget the D plus R plus. Incidence was again higher in the first month after lung transplantation. These findings differ from those reported by previous studies where the incidence of asymptomatic infection was significantly lower. So it means that we have higher prevalence of positivity, but the antiviral treatment was performed just in 62% of these cases of positivity because of a non-responder status. And so, finally, just the 19% of patients were treated with a short period of antiviral therapy. So, about viremia, the viremia was present in a low percentage of 3%, and the incidence of CMV viremia was considerably lower, probably because our strategy was expressly aimed at limiting the infection of the alveolar environment, that is the natural replication domain of the viruses. Finally, the viremia was much more important in case of non-responder than in case of a responder. 23% versus 0% at the first month and 42% versus 8% at the fourth month. This is interesting because of the shorter duration of the ganciclovir prophylactic scheme. The discontinuation rate in our cohort was only of 9%, lower than in the rest of the literature, as we have listened in the first speech. And in our cohort, progressively, the percentage of responder rised from 52% to 100%, and the zero status over time increased from 74% to 100%. What is important to say that this gap was reduced from the first month to the following month of follow-up. Finally, it's important to mention that a constant, probably circulating levels, low levels of CMV DNA are necessary for the correct stimulation of an immunological response. So, in conclusion, the first slide of conclusions gives us this suggestion. This kind of low drug load combined prophylaxis resulted in a low number of CMV pneumonia cases, in development of a natural immunity, and all around the use of an ELISpot CMV assay. Finally, this is a particular field of study. In lung transplantation, CMV bulk positivity, in absence of clinical and radiological data, is the situation of a graft site of infection. It is possible to define when treatment is needed, thanks to the low cellular immunity, and perhaps in the future, after the first month, it's possible to have the referral of zero status. We don't know, probably we have to study it again. And finally, really finally, an universal prophylaxis helps in long-term modulation and the reconstitution of immune response, reducing the need of treatment and the side effects, resistances, which affect our patients in the clinical practice. Thank you very much for your attention. I've finished.
Thank you. I introduce the last speaker, Oliver Witzke. With the title of the talk is "What's on the pipeline and what can we expect from upcoming anti-CMV drugs?"
Dear colleagues, good afternoon. CMV infection has been long a major obstacle towards solid organ transplantation, but during the last decades, major improvements have been taken place, and we have now found regimen where we can solve problems with CMV for most of our patients. Nevertheless, we think that there is room for improvement, and it's necessary to discuss some new anti-CMV drugs, which I'm very confident that we will see in the future. Coming to the challenges in the management of CMV infection. The first thing would, of course, be that we have a good strategy for prevention, and here, first, vaccination is the issue. And today I will also present data of a vaccination trial in solid organ transplantation that gave some very hopeful data. I will not discuss today primary modification of immunosuppression using mTOR inhibition because I believe this issue will be discussed in other sessions. The second issue is prophylaxis. I think on this field, major progress has been achieved, and we have optimized regimens using valganciclovir, and we have a couple of patients where we have limitations in efficacy and also problems with toxicity of the current regimen, and the drug letermovir, which is already licensed for hematopoietic stem cell transplantation, might be an option. I will show you a study that's currently running in kidney transplantation, and we are hopeful to get some data in the near future. Last but not least, the major problem in few patients is refractory or resistant CMV infections. Finally, this is a life-threatening event, and using the drug maribavir, we might get some improvement. I will show you some preliminary clinical data of a recent trial and hope this drug will enter routine or will become routine maybe in the management of this very difficult problem. Well, these three drugs I've already mentioned. Here's the whole list of new emerging CMV therapeutics. To be honest, it's very hard to find any other good drug or strategy at the moment. The Brincidovir has had problems with toxicity in a couple of trials, and to my knowledge has been abandoned as a CMV therapeutic, and most of the other vaccines or cellular or biological agents have only been tested in phase 1 or phase 2 trials, and we cannot await license to happen in the very close future. But now coming to the prevention and the first vaccine trial, the Hokuipa HB101 trial. This is an interesting arenavirus-based vaccine, and it's thought to stimulate antibody as well as T-cell responses to the both of the two incorporated CMV antigens. A study using kidney transplantations from a living donor has been implemented. The study had 3 arms, CMV negative and positive recipients, and either using 2 or 3 doses of the new vaccines and being tested under the conditions of preemptive or prophylactic antiviral therapy. Some preliminary data coming from the company are already available. And here first, a very, very important set of data showing that patients really achieved seroconversion with a 3-dose regimen of this vaccine. The 2-dose regimen was less effective, so I'm quite confident if a phase 3 trial is going to happen, that this 3-dose regimen will become the standard for this new agent. You see the small number of patients here. So of course the full publication is needed for judgment of the data of this study. But even more important, there is also clear evidence that a reduction in CMV viremia and use of antiviral drug could be noted, and CMV disease did not occur in this very small subset of patients of this study. So the efficacy does not seem to be a problem, and these data are quite promising. But looking on the complete data of the study, there's a major problem maybe with this vaccine. There have been few cases of HLA sensitization, 2 of those being serious, preventing transplantation to happen. This issue was taken into account with an amendment of this study. But it's certainly a major issue for a phase 3 trial of this drug, which I nevertheless hope that it's going to come in the close future. But we have to wait. Coming now to directly working anti-CMV drugs, we see the problem that all of the currently existing drugs work via the same pathway, the DNA polymerase. So resistant to the UL54 could be a major problem. On the right, we have 2 newer drugs, the maribavir and the letermovir, which have a different mechanism of action, and they might be very valuable alternatives to the currently available drugs. The maribavir works via the UL97 molecule. The letermovir works via the viral terminase complex. It is important to know about this, as PCR investigations might not be very valid for monitoring this drug, as viral replication is blocked at a very late stage using letermovir, and some incomplete virus copies can appear using letermovir. So it's also needed to look at new strategies for monitoring if this drug becomes a reality in solid organ transplantation. But now first coming to some older data showing the currently existing obstacles with regard to prophylaxis or preemptive therapy. And here we have the VIP study, a study using valganciclovir in a prophylactic or preemptive approach. 7-year data have been published a couple of years ago. One major obstacle is, of course, the time when prophylaxis is stopped. Here we see that 10 to 15% in this medium risk population will get a CMV infection that needs further treatment. Furthermore, there are few patients that are limited by toxicity of this drug, and alternatives would be warranted. And of course, this drug has not shown that prophylaxis was any better than preemptive therapy in the long-term follow-up, so there might be room for better prophylactic strategies. Now, coming to data for the letermovir, this drug quite a time ago has also been used in kidney transplant recipients. Here a study from 2014, where it has been used in a much lower dosage than the currently recommended doses. It's of course a very small study, but it showed some efficacy in preemptive treatment of CMV infection in this patient population. But nowadays it's regarded as a potential alternative to valganciclovir in prophylaxis. And here we see an important trial that's currently running. Inclusion of the patient has been terminated, and we are eagerly awaiting the data. It's a very nice double-blinded trial where letermovir is tested against valganciclovir. A specificity of this trial is that the letermovir arm contained acyclovir, as this was deemed necessary in some countries that contributed to this trial. But we will, of course, see whether it's a good or valuable alternative to the valganciclovir. We have to wait for the data of this. Now, coming to the maybe most important problem or point, there will be a whole session about resistant and refractory CMV infection, so I won't go into detail about this. Here again, a table showing the definition of this disorder. Genetic resistance can sometimes be found, but there's also a substantial number of patients where we can only see the disease is clinically refractory. And the maribavir is currently being tested for this, so I come to the next data for the maribavir. As letermovir, maribavir was first tested as a preemptive treatment for CMV infection. Here, a quite recent paper of the New England Journal of Medicine, where this drug was tested in solid organ and stem cell transplanted patients with efficacy that was similar as compared to valganciclovir. A major difference between those drugs related to the side effects, neutropenia being the most important side effect only in the valganciclovir, and dysgeusia being the major problem in the maribavir arm. But efficacy was similar. Therefore, of course, recurrent disease was analyzed from this trial, again showing similar efficacy. About 1/5 of patients developed CMV recurrence of this cohort, with some mutations being demonstrated in the maribavir. Next I will come to a very important study that is finished and is currently being published, that tested the maribavir in a 2-to-1 fashion against valganciclovir or foscarnet or cidovovir in patients after solid organ or stem cell transplantation having resistant or refractory disease. The primary endpoint was clearance of the virus at the end of week 8, with a lot of further endpoints. Today, I'm only able to show you the data that are available from the public domain, as a publication is still under revision. The main result is a clear difference in the degree of viral clearance at week 8, a more than 30% difference. that is either related to study drug discontinuation being more prevalent in the conventional therapy group. And this was, of course, due to side effects of the very high dose ganciclovir with neutropenia or the acute kidney injury in the foscarnet arm, but altogether very convincing data showing a clear-cut difference in this patient population. If we think about organ transplantation, patients after heart, lung, or kidney transplantation were all included into this study. And the efficacy data were consistent among all these recipients of these transplants. And efficacy was always superior in the maribavir treatment arm as compared to the other investigator-associated treatment arms. So that's a very important study. Concluding, I think I could show that there's a clear need for further improvement in prevention, in prophylaxis, and especially in refractory or resistant CMV infection. I have the very strong hope that there will be a phase 3 study of a CMV vaccine and that the HLA sensitization issue can be solved. Also, I'm very eager for the letermovir data, and my hope is that we will get an alternative option to valganciclovir, especially for patients having problems with toxicity of this drug. And last not least, I'm very confident that the maribavir might become standard of care in cases of refractory or resistant CMV infection. Well, thanks very much for your attention, and I wish you a good afternoon.
So we can open the discussion time. We should have all the speaker, also the speaker online. Hi, good evening. And I don't know if there are for the attendance. If you would make some question, you can use phones.
Yeah, there are two questions from the internet. One is for you. Complete review and very interesting case. Thank you. During CMV reactivations, was your patient found to have IgG hypogammaglobulinemia?
Yes, we tested also for hypogammaglobulinemia, and the patient was borderline level because it was just on 500 milligrams of immunoglobulins.
And then one more question online. Is antiviral resistance testing, genotypic, generally available in EU countries? If so, what is a typical turnaround time?
Well, yes, I think we are lucky because we have at our center we have virologists with many experience in CMV, and but for testing for letermovir and maribavir, we obtained the results in longer time than usually for ganciclovir or valganciclovir. So I don't remember very well, but 7 days. I think it was the time we expected for.
That's all from the internet. Do any of the speakers have questions for the other speakers? I have a question for somebody. Where do allocation policies exist across EU that match for CMV, and where do you see those policies sort of in the overall picture of CMV prevention and treatment?
I don't know if there are my colleagues who will respond. As far I know, there is no allocation policy regarding CMV serostatus in general. I saw a study published from your country, United States, where the author showed that it could be feasible because the concern is the feasibility of also ethical, probably there are also ethical fairs, but this paper showed that it was feasible with a good outcome in terms of CMV infection or disease.
Yeah, at least in France, it's not. We're not allocating the kidneys or any organ according to the CMV serostatus.
Same in Germany. It's not allocated due to the serostatus.
Do you think this is a mistake, or is it just not relevant enough to prioritize?
Well, I think in the Eurotransplant region, I think I would not think that we should add this to this already very complicated scheme of allocation. And our main problem is the very old age of the donors. That's a major obstacle in Europe for transplantation. Furthermore, we do a lot of HLA matching, so it's already a very complicated scheme for allocation.
I agree. I think it's relevant. It's from a medical view, it's absolutely relevant, but it's not really easy to set up because we are looking, as it was said, by the number of very old donors and the HLA matching, etc., called ischemia. It's feasible, but it's quite difficult.
I will make a comment about the talk of Professor Witzke about the problems with the use of PCR for monitoring CMV anemia during letermovir treatment. This is true. I will say that our lab, also regarding the case I showed, back to viremia. For monitoring patient, at least for this case, but also for other cases treated with, not for all patients on prophylaxis, because they use a pre-treatment of CMV of the sample to determine to test then for PCR. But when we use at our center, also in hematological patient, letermovir for treatment, our lab perform viremia. I don't know, there are no comments from the audience. So if
One more from the internet. Dr. Kumar, what is the next step for validation of specific anti-CMV cellular testing as a biomarker to be used in routine clinical practice?
Yeah, I say it's a question for RAtul, because he clearly showed that it can be used, but we should really do some prospective study and showing the impact on the modification of the long-term impact of the CMV rather than just having the biological results. So RAtul perhaps can comment on this because it was part of your talk.
Yeah, no, I agree with Nassim. I think what we need is more interventional studies where people are making changes based on cell-mediated immunity assessment, and we can judge the impact of those changes, preferably in a randomized trial, but otherwise an observational interventional trial. And those are starting to come out, and there'll be many more coming out in the next couple of years that'll hopefully push this over to the next step of actually widespread adoption.
And you'll have to negotiate a little bit the price also of this new tools, because we are adding some new tools. They should have a real impact to have the payers pay for these new tools in the hospitals.
Yeah, excellent point.
Yes, I agree. The cost is one of the major limitations of the use of CMV.
Anyone else, any of the other speakers have any final parting words or questions or comments? Seeing none, I'm assuming we are exhausted after a long day. As thrilling of a topic as this is, I thank all of the speakers for their fantastic lectures. I've learned a lot today. Of course, I'm a surgeon, so I can learn a lot from any presentation that anyone gives. And it's very nice to see Nassim and Oliver and RAtul from across the internet and everybody else here in person. So go forth, stay safe.
Bye. Thank you very much.
Bye.
Thank you.
Thank you.